5% is life-threatening. Normally, the ejection fraction is about maybe 60-65%. Not all of the blood leaves the ventricle with ejection. Some of it stays there. Just like with the lungs, does all the air leave the alveoli with each breath? What is it called? The gas that remains, the residual volume. So what's left is, from the ejection fraction, is kind of like the residual volume. There's some blood that just doesn't get out. And the normal pressure that's inside the capillaries, the hydrostatic pressure, is normally what? 10 to 15 millimeters of mercury. And the oncotic, the pressure outside of the vessels, is the oncotic pressure, and it's typically 25 to 30 millimeters of mercury. Okay, and what type of lung disease is pulmonary edema, whether it's cardiogenic or non-cardiogenic? It's a restrictive lung disease. And as far as these hemodynamic parameters, the pulmonary capillary wedge, which is representative of the capillary hydrostatic pressure, will be elevated. If it's cardiogenic. If it's not cardiogenic, the wedge pressure would be what? High, low, or normal? It would be normal. If it's not cardiogenic, the hydrostatic pressure or the wedge pressure remains normal. What happens to the cardiac output in either? It goes down because the heart cannot put out all of the fluid that has accumulated. What happens to the pulmonary vasculature, pulmonary vascular resistance and the systemic vascular resistance? They both go up.
That's for cardiogenic.
For either.
For both. Okay.
So the only one that's different
Is the
is
wedge.
the wedge pressure. Okay.
Now, think about this for a second. If the heart is the problem, the wedge pressure or the capillary pressure rises. It rises above the oncotic pressure, and fluid from the capillaries move into the interstitial space, around the bronchioles, into the alveoli, and so forth and so on. If there's nothing wrong with the heart, but the patient has severe hypoxemia, they're going into ARDS, if the patient has inhaled some type of gas, if the patient has a low oncotic pressure, anything other than a heart problem, the same fluid is going to move out of the vessel and into the interstitial spaces and into the alveoli, and it's going to end up putting extra work on the heart. But why does fluid move with non-cardiogenic pulmonary edema? Because of increased capillary permeability. Now, the importance of differentiating is because we're going to have to know, does the patient need some type of procedure done on the heart? Stent need to be placed? Bypass surgery? Or does another problem need to be fixed? Because that's what's going to stop the fluid from moving out of the capillaries.
Now, for capillaries that are damaged from radiation, how long does it take for that to heal up and go away?
It really depends on a lot of factors. One thing that may be done is hyperbaric oxygen therapy to help with neovascularization. But it depends on if one's available. It depends on if the patient is able to get into the chamber and things like that. Did that answer?
Yeah. I was wondering, maybe it would be, they were damaged too bad. Would it be like a chronic thing where they're always?
They can't, yeah. It can be. Yeah, because radiation can be, radiation is really bad. But depending on the amount that has to be performed and how often makes things worse. And the more severe the cancer, the more treatment's going to have to be done. I do want you to know the brain natriuretic peptide lab value. Look for it. And what's a normal value? Less than 100 PGs per, yes, picograms per milliliter. And levels that are above 600 picograms per milliliter pretty much indicate moderate heart failure. So along with blood gases, along with chest x-ray, you're also looking at lab values, and this is one of those kind of directive lab values that you're going to look for to associate pulmonary edema. Okay, I wanted to review this slide again. With cardiogenic pulmonary edema, we have to think about the heart being the problem and how to decrease the workload that's on the heart that is the problem. So one of the things we're going to have to do is decrease preload. Decrease the amount of blood that's coming back to the heart. Another thing we're going to have to do is decrease the systemic vascular resistance. And another thing we're going to have to do is support the force of contraction of the heart. Okay? So you'll want to know that either nitroglycerin or morphine can help to decrease preload. How does either of these drugs do that?
They're vasodilators.
They are vasodilators. So the venous system can hold, they're called capacient vessels, remember that term? They can hold blood, increase the amount of fluid that they can hold, and that's what one of these drugs do, is increase the vessel size. Now, morphine has an added benefit in that it does help relieve pain. Nitroglycerin specifically helps relieve pain in the heart. Yes?
Did you say aspirin as well?
No, aspirin's not gonna. Aspirin is used to keep clots from forming, so it doesn't affect the size of the vessels. These two drugs specifically increase vessel size. Aspirin's more like a heparin. It is more of an anticoagulant.
I just saw nitroglycerin and I always thought like aspirin and nitroglycerin usually go hand in hand.
But they
That's why I
do
was
separate
like-
things.
Yeah.
They do two different things. Okay? So, afterload reducers also increase vessel size. Nitroprusside, Catepril. Again, these are vasodilators, just like the other ones, but these are more on the arterial side than the venous side. These are more of arterial dilators as opposed to